Today on Beyond the Chart, we're looking back at the conversations I've had on the podcast with one consistent theme in mind: the patient. We've been joined by oncologists, researchers, technologists who have all dedicated their life's work to the patient, to help manage their disease, of course, but really to help them as people. Their commentary on the show has been inspiring, illuminating, and sometimes even emotional. I often like to point out the irony that we bring more technology into care, so care can be more human. These leaders are all at the center of that effort. I hope you enjoy hearing from them. We start with Kathy Oubre, the CEO of Pontchartrain Cancer Center, talking about what it means to treat people she sees every day in her Louisiana community.
These patients are not just patients that walk in our four walls. They're also our neighbors, our friends, people that we see in the grocery store, in Home Depot, and people that our own children have gone to school with, a lot of the children of our patients. So it's been a really fulfilling thing to do for the community as well. So getting back to ambient AI, Flatiron asked us to be a pilot, and DeepScribe was far enough along in its development that we thought it wouldn't be, too disruptive to the provider-patient relationship in those visits. So we decided to give it a shot. Interestingly, and I know we talked about this, Matt, the clinic visits now are not actually shorter, they're longer. But that's not a bad thing. And why? Because by having the provider not facing the screen and directing his or her attention back to the patient, we've seen increased provider as well as patient satisfaction by just, again, having that ambient AI running in the background, but going back to why our providers went to medical school part of that is to get back to that relationship. And so much of that has been overlooked over the last several years. It's like any relationship. We want to be able to see the patients. We want the visual cues of those patients and their family members that come with them. They really do matter within the visit. And immediately, even though the visits were longer, the providers, the patients, and the family members were happier. We saw, satisfaction scores in all those groups go up immediately. And by extension, it also helps deepen that trust factor, between the provider and the patient, which, essentially just by allowing the patient to be more vulnerable with the clinician, facing someone, maintaining good eye contact, it demonstrates all the stuff that we were taught, in school, in kindergarten. It demonstrates presence, interest and respect. And all of those things help build trust. And, just an even deeper rapport, which strengthens connection by conveying, honesty for the most part, and ensuring that, that mutual understanding between the patient and the provider. And, that's what everyone has felt at Pontchartrain as well, patients as well as providers, that ambient tools like DeepScribe have allowed the providers to get back to that deeper interaction with their patients.
The next is Dr. Diane Reidy-Lagunes, the chief of medical oncology at Duke University. She talked with me about making that human connection with patients and her view of physician burnout.
A cancer diagnosis is probably the most terrifying moment that most of our patients and their families will have, or at least one of them. And so my responsibility is to help them in that journey. And I think oncology sort of demands that. It's an enormous honor and privilege, but it's also an enormous responsibility. It also demands that you understand the science, especially today, right? Like, thank heavens, technology has taken off. We learned and understand so much more about the thousands of diseases we call cancer. And so you have to have an understanding of the language of the science and especially in academic medicine, where I say that we have a responsibility of our patients of today and tomorrow through the clinical trials and the scientific discovery that we're trying to pursue. So I think you need to have that science piece as part of the deal and understanding that. But you also have to recognize that human aspect of how terrifying the diagnosis is and how important that compassion is to understand where the patient is to meet them there. Because all patients are, it's different tones and it's different places that they're going to be. And sometimes they may be in one place, but their family is in another place. And I always say cancer is a family disease. And so how do you navigate all of that? And that's not something they teach you in med school, right? And I think in some ways, to your point before, a couple of years off gave me the insight to understand people a little bit more, different cultures, different understandings. And it was such a blessing and a gift to have that. And unknowingly, I think I brought that into my career as an oncologist. So I think, to me, that's a very, very special place to be in a place where I love to understand the science, but then bringing that back to the bedside and helping our patients is incredibly rewarding. You and I had talked about like burnout. And I think what physicians and clinicians, nurses, APPs, and docs feel that is so incredibly frustrating is burnout is not working to see 40 patients in a day. I actually can do that, and I love doing that, and I would continue to do that. What burnout is the ability to not see the patients because I have to be chained to a computer. Like, I refuse to see a patient with cancer in the clinic and look at a computer screen. I just can't do it. It's just not who I am. And yet people find that they're not, like, their doctor's no longer talking to them. They're talking to the computer because they got to document it all, And so when did that happen? How did that happen? That it's almost like I actually grieved when we moved on to the electronic medical record of my old institution, that moment, because I just can't do it. I can't open a screen when I'm supposed to be talking to a patient about potentially that their cancer has progressed or that, that they have incurable disease. It's just sort of like, where's the compassion there? Now, thanks to folks like yourself, now I could say, we're going to record this so that you and I can be able to have this conversation. And a scribe could help me document what I need to document and do all the things that I need to do. And so we could bring back that compassion to the bedside, literally and figuratively, by not worrying so much about that administrative burden where if, docs would say, well, if I don't do it now, I'm going to have to do it at 10 o'clock tonight instead of being with my family. And so that sort of either or is now something that you don't have to choose, which I think is incredibly exciting.
Dr. Guri Doshi is one of the most thoughtful leaders in oncology today and one of the busiest. Medical director at Texas Oncology, P&T chair at US Oncology. She also happens to be a great friend and collaborator.
We focused on the patient's cancer, but what you're asking about is let's focus on the patient. And so the elements of that patient journey, the pearls that really you all have captured and I see captured are elements of their social history. So this is beyond just social determinants of health that, yes, we can look at zip codes. Yes, we can look at socioeconomic status. Yes, we can look at employment history and kind of put together pieces. But the pieces that we're not putting together are the emotional pieces, the pieces of, is this person a mom? What age are her kids? What really is her concern, right? Is it the breast cancer that she has, or is it the impact of the adverse effects on her ability to mother her children? Will she be able to be feeling energetic enough to take care of them when they get home from school? So we pick up pieces of their social history. We pick up pieces of what matters to them. And that's essential to the patient's quality of life. What motivates you as a patient? What do you consider as good quality of life? These are discussions that we have all the time. When a patient has an incurable cancer and I'm in the position of talking to them about data on quantity of life versus, and we have that data in our evidence-based trials and we understand exactly how to frame that conversation in terms of therapeutic selection and what they can expect. But Where are we in speaking about their quality of life, not just the quantity? So AI and technology has the ability to pick up the 360-degree view of what that patient is experiencing. And it helps us to better support patients in that journey. If they have children, they can't have an afternoon appointment, right? They've got to get that 9 a.m. appointment. And wouldn't that be wonderful for us to say, okay, here we are. This is where we have to take care of this patient so that they can get in, get out, get the treatment they need, and move on with their life. Because that's what we want them to do. We want them to have a wonderful, high quality life on that cancer journey. We want to be able to support them. The other part that we never consider is the caregiver, right? And so what you're picking up in those conversations is not just the voice of the patient, but you're picking up that conversation and that interaction between the caregiver that's sitting next to the patient and then the patient. And oftentimes, Matt, we learn a lot of history from the caregiver, right? And so what they're truly experiencing at home, what are the side effects? How are they coping? How do we support this? You know, what is the health literacy? From the questions they're asking, we can deduce that.
Our episode with Dr. Douglas Flora is one of a kind. Dr. Flora is an oncologist, author, technology entrepreneur, clinical leader, and cancer survivor. He's also an exceptional storyteller.
I understand, Matt, for your team, how hard it is when you're trying to listen in on my visits and your engineering team can't possibly know that the date of the daughter's wedding is a critical piece in how I'm going to choose chemotherapy.
Yeah.
Because it sounds like it's fluff. It sounds like it's vacation talk or, what day is your daughter getting married? But to that man, walking his daughter down the aisle is mission critical and has a thing to do with the aggression that we're going to pursue with the chemotherapy drugs. And how do you teach an engineer that other than just being with them long enough, do they start to pick up on the nuance of those things? I'll give you the other example is one of my patients, we start out every, conversation. How's life on the boat? She lives 3.5 hours away on a houseboat in a big lake and loves it there. That's her happy place. But she insists on driving back to me for treatments. So if you're designing a clinical decision support, you may not understand why I'm ignoring everything the engineers put first, second, and third on that drug list. And I'm going with the 5th drug because it's only given every 28 days because I'm trying to minimize her windshield time. Perfectly reasonable decision, but it probably doesn't make it into my progress note. What you understand is that it's that human aspect of communication and the things that you can't possibly capture with a microphone. The daughter getting hives on her chest because you're sharing information too much. The husband is getting vagal 2 seats over and you see him starting to gray out and you've said too much. I can't teach your engineers that, but when you find that the tools don't work as well as they've been designed, that's because the patients don't either and the doctors don't either. We're literally, the entire visit can change if you find out that the granddaughter's pregnant.
Yeah.
The entire conversation is different than the engineers engineered because we don't talk about cancer for the next 15 minutes. I know how terribly frustrating this is. And I will tell you, I'm not immune to this. What if we look at your tool and 2 years from now, you have a tool that will call out to a clinician a signal that they might not notice because it's subtle. And I'll use an example of MCV. MCV is in a blood count. It's almost every patient has it tested. The MCV starts to go down when you become iron deficient. Okay. Even a normal MCV that's 12 points lower than 2 years ago is a cause for concern because it means that probably the body's conserving iron and making smaller red cells. If your pattern recognizers can start to put that in, even if your engineers put it in red, when you put that thing and you pull that into the patient's progress note, if the falling MCV is highlighted saying patient may need iron studies, that usually happens 8 to 10 years before a colon polyp becomes a colon cancer. I cannot tell you the hundreds of patients that we take care of in this building for stage 4 colon cancer that when we look back, they had a falling MCV 8 or 9 years before. Your tool can find that. Your tool can poke me and say, are you aware this MCV has fallen by, your engineers can choose the number, 12% over the last 12 months. Would you like me to add iron studies?
Yeah.
You probably just save more lives than I can with chemotherapy. Your company, your engineers probably save more lives because now those patients will be identified as stage 1s or as colon polyps that never need chemotherapy or resection. I think that's the power of the tools that you're building, is when you can be the pattern recognizer and start to nudge us to find that signal in noise, because your computer never sleeps, right? The compute doesn't get tired. It doesn't fight with its wife. It doesn't get sleepy after lunch. To help us make sure that that patient at 4 o'clock on a Friday gets the same eyes that the patient at 8:30 on Sunday or Monday mornings did. That's when you produce value, right?
Dr. Leyland Wilfong, now Chief Medical Officer at Navista, talks about what it means to care for the whole patient during and in between visits, with an eye on the patient's family and other caregivers.
How do we take what happened in that room and make sure that we're managing that 24/7 outside of the room work that needs to get done? So, for example, if a patient, a patient had a side effect and the physician gave them a medication to manage that side effect, can we be alerted about that so that I know that my nurses need to call that patient the next day and say, hey, is that working? So that we can continue that at home. I mean, I can't tell you how many times I've had patients where, they may have diarrhea, for example, and I give them a script for Lomotil and I give them instructions how to take it. And they come back in the next time and it's not any better, and find out, well, they weren't taking it the way I told them to take it. And so how do we have that connectivity to make sure that whatever happens in that room, we know, so that we're following up with our care team on those things? And then you talked about nudges and predictions. Are there things that are said or unsaid in the room that we need to be alerted about so that we can think about things a little differently? Is there a subtle thing that, somebody may have said? And I'll tell you an example that happened to me not too long ago, sitting in a room with a patient and their family member. And I said something about treatment. And I just noticed that the family member got this look on his face. And it prompted me enough to stop and go, are you okay? Is there something that needs to happen? And then I got the whole information about him having to take off work, and he was an hourly employee, and then how, that was going to, he was his primary caregiver for his father, and blah, blah, blah. If I hadn't noticed that or caught that, he would have just taken off of work, not gotten paid, and been in a financial distress. But, there are things like that happen that we can then proactively kind of jump in and go, okay, hey, here's your problem you didn't want to talk about. And I work in a blue collar, more rural clinic right now. And so nobody ever complains about that stuff, right? They just suck it up and do it. That's just how this population is. So is there something we could do more proactively? Call them and say, hey, let me help you with this. Let's see if we can find resources and things to do that. Those things would be super helpful for us.
What can I say about Dr. Deborah Patt? She's an accomplished oncologist, an executive vice president at Texas Oncology, and president of the Community Oncology Alliance, and the chair of ASCA's AI Task Force. We talk about clinical knowledge in the moment of care and the patient education that's needed after.
I've been doing this a long time, for 20 years now. So my ability to understand how to treat someone's breast cancer is right at my fingertips, and it has been for a long time because I've had a lot of education and a lot of experience. And so that's the easy part. I think the hard part sometimes is getting patients through that journey, making sure that they're educated appropriately, making sure they understand how to put cancer in the context of the rest of their life. Because, while we've seen innovative therapies evolve, and that's completely amazing, we don't just want to make cancer not be the ultimate journey for patients, right? Because we want to control their cancer, but we want for cancer therapy to not disrupt their lives. And so I spend a lot of time trying to help patients navigate that journey, providing them education, trying to provide a personal experience for them. And that's why me operating at the top of my license is really critical, because I want my interaction with patients to make them feel better, to make them understand how they're going to live their life. I don't want them to see the back of my head because I'm typing on the computer. I don't want them to see the back of my head because I'm typing in orders. I want to be present with them. And I want to be able to, touch them when they cry and hand them a tissue and walk them through education. And I think that helps patients live much better through their cancer journey. It never ceases to amaze me, Matt, how different people can be affected by cancer variably. I have patients that have pre-invasive breast cancer, DCIS, that will likely never contribute to their morbidity or mortality, and it can plague them. And other patients that have metastatic advanced cancer that live their lives very normally. And I attribute, to some of that, there's some difference just in patients, but we can help a lot with that if we can really be present for patients and educate them. Knowledge is power. And so if we can be better educators and help patients navigate their journey better, then I think we've done a real service to executing on this mission of great cancer care in our communities. Clinical decision support should act to nudge care delivery choices between doctors and patients. But at the end of the day, those are choices between doctors and patients. As a breast cancer specialist, again, as I've already said, I've done this for 20 years. I usually know within 30 seconds of walking in a room what I need to do to treat someone's breast cancer, whether they're new to me or have new progression. Like in my life, that is an easy decision. Mm-hmm. But what is a difficult decision is the many other things that interact with a human to make care delivery complicated. So I'll give you two examples. One, a patient that I had this last month who is a 30-year-old who's a survivor of an early stage breast cancer. And she had had a headache, and another doctor had ordered an MRI, and it had an abnormality in her brain, in the covering of her brain. And when I saw this, because I ask all patients to send every scan they ever have to me, I said, "Oh, you need to come in. We need to talk about this." I sent her to the neuro-oncologist thinking, gosh, it's possible this could be breast cancer. She got a lumbar puncture. It was negative. And I had her come into clinic to talk to me about what to do next. And she'd followed up with the neuro-oncologist, and they said, you know what, this is inconclusive. It doesn't really show anything, but this is really an abnormal finding. You should probably have a brain biopsy. This 30-year-old woman was trying to get pregnant. And I said, oh, this is, that's a severe thing to have to do. I said, is there anything else from your medical history at all? And she said, Dr. Pat, about 10 years ago, I had a very severe case of cat scratch disease. I was like, okay. And I was like, I could remember back in the depths of medical school that cat scratched, and I am a trained internist. So in internal medicine, that's Bartonella henselae. That's like the bacteria that causes cat scratch disease. I said, I think cat scratch disease can do some weird stuff, but I couldn't remember, right, what exactly all it could do. Probably I knew that at some point, but not today. And so I opened up my computer, which I always have next to me in clinic, and I looked on open evidence. And I said, what are some of the central nervous system effects of cat scratch disease, and can they be chronic? And so it gave me a list of all of the effects of cat scratch disease and their chronicity, and it gave me links to the peer-reviewed literature. And I opened up some of those articles, and I talked about them with my patient. And I said, I think that this is probably unrelated to your headache, and it's probably always been there. And we can probably spare you a brain biopsy and follow this over time, because likely this is not your breast cancer. The type of breast cancer she had just doesn't usually go to the brain. She had an early stage breast cancer. It's just unlikely to be breast cancer. And so that tool, the large language model that Open Evidence provides for me for free, made me a better clinician and spared my patient unnecessary testing. And historically, we've approached patient education kind of as a one-size-fits-all scenario. Like we give them black and white handouts that are reflective of common toxicities in alignment with the FDA US package insert for different drugs. But that's like reading, a car manual. That's not easy to read. Most of our patients and their caregivers don't want to consume education that way. We actually have a pilot right now in Texas Oncology where we're doing video education, where the video education for patients is in like these 1-minute snippets, kind of like a TikTok video. I'll never be a TikTok star. I'll just say that right now. But it, provides it in small bits of digestible content, I think, in a way that people want to consume it. And so we need to be very patient focused and get feedback from patients, I think, about how we evolve the patient education piece. But in my mind, that's a real unmet need.
On the subject of ambient AI, Dr. Sean Kozin, the head of the CEO Roundtable on Cancer, finds that how a patient says something is just as important as what they're saying. Here, he talks about that sacred communication between doctor and patient.
One of the conversations that we had recently is around when patients are telling the physician their story and their symptoms, the way they articulate those symptoms can be missed because you have to really pay attention to their affect. And by doing that, you can pick up a lot of interesting information related to their mood, related to maybe the level of pain that they're having that they're not able to articulate or characterize accurately. And in my case, being a thoracic oncologist, I've picked up a lot of brain metastases on the phone just by talking to patients because they haven't been the same. And they've just sounded different and their affect has changed. So those signals are quite important. Physicians are obviously trained to look for those signals. And the more you see patients, the better you become at those. But at the end of the day, it's all based on your intuition and how much you can focus at the point of care when you're talking to the patient. So it's, it may not be consistent, but the way that patients articulate their symptoms underneath that, beyond the semantics of what they're saying, there's a lot of valuable information that an experienced physician, and now I suppose a properly trained voice recognition model can certainly pick up. Before the advent of electronic health records and what we call managed care, where physicians could spend a lot of time with their patients. They even made house calls in some cases, and they really started to get to know their patients and how they articulate, their problems. Every patient is different, and they started to gain a lot of intuition about each individual patient, how they see the world, how compliant they may be with recommendations, and how they express themselves. We've lost that because of several reasons. The volume of patients that physicians are seeing right now have been increasing, but more importantly, the documentation burden has exponentially increased in the past couple of decades. So that has had the unintended consequence of eroding the therapeutic bond between the doctor and the patient to the point that visits are very transactional. And you hear all the time, for example, from patients that when they see a doctor, the doctor is not even looking at them. They're just looking at the computer monitor and typing and just trying to listen at the same time. But that's not a very conducive environment for really understanding the patient and what they're saying. And the best that you can do is just to validate your own assumptions, which is not necessarily what a physician should be doing. But ambient scribes, I think, are taking us in a way back to the time where physicians now have an opportunity to rebuild that relationship and to really start to understand the patient in a holistic manner. Now, what that really means is that the signals that one can get from these audio files are quite interesting and fascinating. At its most basic level, it can accommodate what we need to put in the electronic health records, which is frankly based on standards that try to create a framework so that you can put all the right data elements into the EHR. We can now go beyond that. So what are some of those parameters? I think we touched on one of those earlier, that the way that the patients speak, just the affect that would be reflected in how they express themselves. And in fact, if you even visually look at the audio file of audio waveforms, without AI, if you just look at it for a patient that has a flat affect, it is actually quite flat because they don't have a very broad, what we call dynamic range. And that also exists in music, by the way. So it's quite interesting that a patient with a flat affect would not have a very broad dynamic range. The waveforms would be almost compressed. And AI can pick that up very easily and more. So that's one example where the signals can be used to go beyond what the clinician might be able to assess during the visit.
Dr. Sanjay Juneja, the Onc Doc, has educated hundreds of thousands of followers online, and recently with a new book for patients and their families. We talk a lot about the ways technology can and should move medicine forward. Here, Sanjay talks about the complexities of patient access.
I was shocked yesterday when I was talking to a buddy that's at Stanford, and they were talking about how when it comes to cancer patients, and we have to deliver steroids for like immune therapy, toxicity, or for any lymphomas, usually or most lymphomas, they were like, think about the time that's lost to have to go see an endocrinologist. And then when they expanded, they said, if you say you're going to refer a patient to the endocrinologist, they're like, the time it takes for the referral team member in your clinic to call the clinic, gather all the information they need, make sure you have that information, those labs done and stuff, and then actually schedule you lost time for the patient. And I was shocked. I was like, that's your time crunch? I'm like, our time crunch is that it's 2 to 3 months before you can see the endocrinologist. So it was a completely different context of, days lost before starting therapy for lymphoma, but the impossibility of not being able to wait to start therapy for lymphoma because it's, our diabetic endocrinologists are oversaturated. So you could imagine how if there was an ambient learning, how even that in a conversational context, if you were to say, hey, we're going to send you to a diabetes specialist because, we're going to get your sugar super high and we don't want to hurt your kidneys, it means two different things. So when you're approximating it, down to the bottom of the assessment and plan, one is doable in a week or two. You see them back and you can start your therapy. The other one is in lieu of the fact that we can't start therapy, until we have to start now, not 2 months. Like the entire flow changes. But
Exactly.
It's like I didn't have to prompt it. I didn't have to teach it. It's just if you have an entire institution of physicians, and especially when they're like, it looks like the appointments in so and so weeks or months. It's intelligence now that's able to learn about even the times these kind of things takes. A PET scan, for example. Sometimes we have to push back appointments because there's just not a PET scan available, which is a completely never problem in other places. So it's a very interesting concept that really kind of pairs well with this idea of just ambiently, no pun intended, starting to come into our lives in a convenient manner. Like that's the key, is that it's so convenient. Like you almost, it would be weird to not have it.
We close today with a trailblazer in cancer survivorship care, Dr. Lydia Shapira. Lydia and I talked about AI becoming a growing part of the process for patients, and when AI may become part of the standard of care in oncology. A lot of the stuff that we've been talking about, to me, leads to a world where ultimately AI-assisted care, or care that's delivered with the assistance of AI, will ultimately lead in a better patient experience. Would ultimately lead to better clinical decisions. Ultimately lead better to better patient outcomes.
My thought, not based on a lot of knowledge, but where I see this going, is that it's going to be part of the delivery of care, and we just haven't quite figured out the extent. Because there's sort of different levels of adoption and different levels of comfort. But I think this is going to be part of the delivery of care. I mean, we've moved from, in my time, say, as a specialist, we've moved very much from the dyadic model where it was communication. When I thought about it, was my patient and communicating with me, to understanding that there are many other people involved, and now basically to a team-based care model. So if you are, researching health services and implementation, it's all about delivering care as a team. And I think the AI is going to be part of that construction of the team. So I think that if you ask me, I don't think it's going to be optional. I think it's here. I think the smarter practices and forward-looking systems are going to be pushing what the AI can do to serve, and I think that that's the part that I'm very interested in. The evaluation of AI. What is it really costing us? What is it really doing for us? How is it impacting on patient satisfaction? And in the case of cancer and cancer survivorship, which is my field, my perspective and my slice of this action is it empowering patients to be healthier, to feel more capable about handling their health, because we know we've now handed them after cancer all of these other health challenges. So how can we prepare them to navigate a fragmented healthcare system and advocate for themselves and know what it is they need to do without needing to professionalize their illness? And I think AI can help us.